Welcome to part 2 of the lecture. I'm doing this lecture in screencast instead of um, WebEx since we've been having some issues with WebEx. But screencast, if the files are too long or too big, it takes forever to upload and sometimes they don't. So I'm doing this lecture in 2 parts. So I realized my PowerPoint skipped over the joint, which will help make a lot of sense. So this is a knee joint. You have your muscles, your tendons, ligaments, your joint capsule. This is the bone, your bottom bones, your upper bones. And so what you have is synovial lining, or this calls it synovial membrane, and then the synovial fluid. And what happens in juvenile arthritis, because it's an autoimmune disease, and autoimmune means that your immune system basically turns on your body and attacks itself and thinks your body's a traitor. So normally our immune system is supposed to fight off invaders, right? Foreign things, infection and bacteria and foreign things in our body. And so what happens in juvenile arthritis and these autoimmune inflammatory diseases is your body thinks that the joint itself is a foreign invader. And so what happens is the synovial lining kind of becomes very angry and inflamed and gets filled with inflammatory cells and starts eating away at the bone. And you can see the swelling that goes on here and inflammation. And that's where you get the bone damage and the erosion. And so what happens is when you have damage to the bone and the joint, it causes actual damage to your function or your range of motion. And so, which then causes loss of well function and range of motion ability to do things. So, like, my elbows don't straighten all the way. My fingers, even after several surgeries, it's much better than it used to be. You guys should have seen me before with my hand. I couldn't even open my right hand, but very deformed. And so it's not just the deformity of the cosmetic, but because of it, like I don't have a full grip. I can't straighten my elbows. So that, of course, affects function. And unless you get like a joint replacement, like I have done in other joints, they can't really joint replace fingers and things like that. They could announce tomorrow that there's a cure for juvenile arthritis. Everybody line up and get this one shot and you'll be cured. That doesn't matter. I still won't be able to straighten my elbows. I still won't be able to grip my hand, and all the other, I still won't be able to open up my jaw all the way, all the other deformities and loss of function that I have. So even if you have eventually have really well controlled arthritis, the all the damage that's been done is not reversible unless like you have a joint replacement of the joints that can be replaced, like hips and knees and things like that. So we're better with the medications. I'm not going to go into the whole last 50-year history of juvenile arthritis and how when I started, I took 100 baby aspirin a day when I was little, and now we have many more sophisticated drugs that don't just try to treat the symptoms of inflammation, but really the biologics really try to go into the immune system and flip the code or interrupt that autoimmune process from the start. So we're getting better. So hopefully kids that are diagnosed now won't have all the deformities that I do because we're able to start them off early on with better meds. Like I said, it doesn't matter that I'm on these great chemotherapy and DMARDs and biologics now, which are these classes of meds that didn't exist when I was younger. I still have all the deformities, even though I'm able to take those meds now. Versus kids that are diagnosed now, we can start them off on those meds. So hopefully their disease doesn't get out of control enough to cause a lot of joint damage and deformity. And there still are kids with severe arthritis that we have a hard time controlling that do have these deformities. But it's much better. For instance, my kids arthritis camp that I'm the medical psychosocial director of. When I went there, like pretty much everybody was in wheelchairs. It was really unusual to have somebody walking around. And now it's really unusual to have somebody in a wheelchair on a daily basis. They might use it for a flare after surgery or the day after the dance when we've all overdid it too much. But it's a very different, when you used to come to my camp when I was younger, everybody was wearing braces and wheelchairs. We all had deformities. We all walked weird. I mean, you could tell something was wrong. Nowadays, it's very much a hidden illness where you look at a kid and they look fine day to day. So we've talked about with some of the other diseases, when you have a hidden illness like cystic fibrosis or diabetes or things like that, where kids, someone can't just tell, can look by telling, someone can't tell just by looking at you, excuse me, that you have a chronic illness, that causes its own host of psychosocial issues and concerns where people don't believe you and the stigma and do you tell people or not because you can hide it. And those ones that we've talked about with like diabetes and cystic fibrosis and things like that. Again, that website is called But You Don't Look Sick. We hear that all the time. But you don't look sick, or you're just a kid. You can't have arthritis. So that's the process of inflammation and the whole autoimmune. So another thing to help you is here again is a knee joint. And here's the synovial fluid, and then here's it getting angry and really inflamed, and you can see that in the joint, how that would appear from the outside and starting to eat away at the bone. And then to distinguish that from osteoarthritis, this is also the knee, but it's kind of a side view. That's like the front of your kneecaps. So a healthy joint looks like that. Osteoarthritis, it's wear and tear, compression on the joint. So it's mostly elderly people from years of wear and tear. We're also seeing it in younger people in certain joints that are in the military from doing a lot of, that are deployed, a lot of walking, being on their feet for miles and miles and days at a time, carrying the 50-pound rucksack. So not just from like basic training or something, but people that are deployed in war zones. So we're seeing it in these young, healthy males and females more and more now, specifically like the knees or ankles or shoulders, things that would be affected. And then also sometimes professional athletes that have a lot of wear and tear on a certain joint because of football or tennis or whatever their sport is, and they're with training and being a professional athlete and having it over and over and over, they can get osteoporosis younger than like the elderly. But typically osteoporosis is like your grandpa's arthritis. And then you could kind of see the difference from osteoporosis, that wear and tear on the bone you can see here, compared to the inflammatory arthritis, which is juvenile. This is adult rheumatoid, but the inflammatory process is the same. So, okay, I don't know why we'll go back to this. I don't know why my PowerPoint skipped over that. I really apologize for all my sniffling. It is allergies. And I worked overnight last night, so I've got that night shift hangover going. And it's a snowstorm out. Okay, I apologize. If that really annoys someone, I'm so sorry. So suspected causes. Okay, I have to pause this thing. Okay, apologize for that. Suspected causes. So, like I said, it's idiopathic, meaning we don't really know the cause. Some people think there's like a genetic component to it. There used to be some better theories than there are now that have been disproven. So really, we don't know. That's all I'm going to say. So literally when it says whoever has, I didn't look, whoever has that overview part in the blog and it says what are the causes, you can say it's idiopathic. We don't know. Idiopathic means we don't have a cause. We know it's not contagious. We know it's not infectious. Although there is theories that you can have a genetic predisposition for it and then something has to like flip that switch and turn it on. So one of the theories is like me and my sister's healthy as a horse, was in the army, did 2 tours in Iraq, has 2 kids, works full time, runs around. Her only illness growing up was an ear infection, just, has never been in the hospital other than to deliver her babies. And then there's me. So one theory is like we both have a genetic predisposition and then something in infancy flipped my switch to turn on that JA gene or whatever and didn't turn her gene on. So one of the theories is that it could be like a super high fever or some sort of infectious process at whatever age. So for me, it would be infancy when that switch flipped. Sorry. Oh, my night shift is showing. Um, and other theories are it could be like some environmental exposure. At one time when the evil Wakefield used to be Dr. Wakefield lost his medical license because, he was the one that did the fake research study that show he tried to show a connection between vaccines and autism, and it turned out he was not doing proper research method, and he was money on the side. And anyways, that was disproven. There's no link between vaccines and autism, and he lost his medical license and is still wreaking havoc trying to push his propaganda, but he is not a good guy in my book. But anyways, during that time when that was kind of coming out, people thought, well, maybe could one of the vaccines, like in infancy or at a certain age, be something that triggers or flips that switch, and that has been disproven. But there's still one of the theories out there is still this double hit theory that you have to have a genetic predisposition and then something we don't know what flips the switch. And there's another theory that maybe there's not just a genetic predisposition for arthritis, but it's like all these autoimmune diseases like muscular dystrophy and multiple sclerosis and all these that are kind of a family, and something determines that you have one versus the other, flips the switch. There's people doing kind of work in that area, but they don't really know. So there are families where the mom has it and the kids get it, and there are also families where the mom has it, none of the kids get it. There are some sibling pairs that have arthritis, and some, like my family, where I'm the only one that has rheumatoid arthritis. Like my parents now, are over 70. My dad's got some osteo in his knees, and my mom in her hands because she was a educational interpreter for the deaf for years and years. So she used her hands a lot. So she's got some osteo in her hands and things, but not rheumatoid process. So Cincinnati Children's has actually done a study for years and years now on sibling pairs. So multiple siblings in a family that all have some form of juvenile arthritis. So they come out and they study them and draw their blood, and there's a longitudinal long-term study that's been going on at Cincinnati Children's for that. So what are the treatments? Medications. There's oral medications, injections, and infusions. The new biologics that are out that pretty much every kid upon diagnosis gets on either come in injection form, meaning the parents have to learn, or the kid when they're older to do injections at home, or an infusion where they go into a clinic or like a day treatment center kind of thing like DTC and get an IV. Or I have a port now after all these years, but that's pretty rare for kids with arthritis. Most of them still just do a peripheral IV and sit and get an infusion. So big child life interventions and life skills for this are teaching pill swallowing, teaching coping with injections, teaching coping with IVs, helping parents learn how. I mean, can you imagine a 3-year-old you've got to give an injection 3 times a week to, and screaming and kicking and crying, and the dad's got to hold them down while the mom's got to give it, or you have a single parent trying to do it. Like, that's one of the biggest things on these parent blogs that they just stress over. And some of the kids, as they get older, they start bargaining. Well, I don't want to do that. How do you hold down a 10-year-old to give them an injection when you're the one parent at home? So that's a big thing. And what's happening is a lot of this is at home, or getting them to take their pills and pill swallowing. And because, sorry, I don't know why I keep leaning on my pad. Because even though the disease processes are different with adult and juvenile arthritis, most of the medications are the same. And so because the medications are originally designed for adults, it's very rare for an arthritis medication to come in liquid form. Not like the antibiotics and some of the other meds that we have that get geared toward, more kids get these infections or get these issues, or some of the asthma meds that can come in liquid form. It's very, very, very rare Prednisone really is the only one that I know comes in liquid form and it tastes like boo hockey crap. Even the pill form, if you leave it on your tongue very long, so most kids won't even take the liquid form. In fact, when we give prednisone or steroids for like asthma or other respiratory things in the ER, we actually give them the IV solution orally for dexamethasone because that it still tastes like crap, but it tastes like liquid prednisone tastes just horrible. So there's not a lot of meds that you can give the IV solution for orally, but like dexamethasone and prednisone, the steroids are one of them that you can. You again don't have to know this, but that's how bad it is. So, and there's not like the chewable forms and things like that. So pill swallowing is like a life skill for these kids, as well as you'll learn about with the shortage of arthritis or the shortage of pediatric rheumatologists. A lot of times they're coming to the children's hospital where you likely will be working your center like once or twice a year to see the pediatric rheumatologist because there's such a shortage and they have to fly, drive, cross states, get out of work and school, pay for hotels and food. And then they're getting managed at their home community clinic kind of day to day. So they're getting their lab draws there, they're getting their infusion at the adult clinic. So they often don't have child life for their infusions, even though they're going to a clinic, and obviously not for their injections at home. So one of the biggest things that Child Life can do is if you're covering like a specialty clinics, like in our AFCH, like if you would be the second floor Child Life specialist, would be, sometimes I think these kids get overlooked by psychosocial providers because it's like, well, they're just here for their, twice a year or every 3 months visit. They're just coming to clinic. The rheumatologist is going to feel their joints and, do some range of motion on their joints and examine them, do a simple physical exam. But really, it's going to be a lot of talking about how things have been going and symptoms and maybe changing meds. So I think a lot of times they get overlooked by, not just us, social work and other psychosocial providers, but it's like we're not getting any, procedures. They're not specifically in an acute flare or exacerbation or pain right now. They're just coming from normal clinic visit. I don't need to see them. And as we go through the treatments and all the other psychosocial issues, my argument is you do need to see them. Child Life does need to see them. These are kids that are going through a lot of treatment and injections and pokes and psychosocial issues at home, either literally at home or at their like home community clinics, and they don't have the support. So when we have them in our children's hospital clinic, we need to be seeing them and teaching them these coping skills and talking to them about Buzzy and LMX and Shot Blocker and other modalities and teaching non-farm pain management skills, helping the parents learn comfort positioning and techniques for giving shots and, sticker charts and behavioral management because they're not like other kids that come to the children's hospital every time for their treatment where they have Child Life right by their side. They're doing this at home. And that's why I think the anxiety, just the procedural anxiety and the other psychosocial issues sometimes just ramp up because this is one of the diseases that's managed such outpatient that we don't have them in the hospital. So obviously today you're going to prioritize your schedule, and if you're covering another clinic too and kids are actually having procedures or bereavement, that's your priority. But I think sometimes they get a little blown off and never get seen, or it's like, well, I'm just covering a rheumatology clinic today. I'm going to do all my projects in the office. I don't need to see them. And my argument is you do, because what happens is I see them once a year at camp with a whole host of issues that I'm trying to fix. But the parents really go through a lot too, and the siblings. Like they have all the same psychosocial concerns as all the other chronic illnesses that you're seeing, even though you're not seeing them inpatient a lot. So they have less support because their treatment is not typically inpatient. So if you learn nothing else from that lecture, please take away that. So, and they're going to have these for the rest of their life. So it's life skills for them to learn this. This is like learning to brush their teeth. They need to learn how to swallow pills. They need to learn how to cope with pokes. Because they also get labs. So all these medications can cause side effects to like your liver and your kidneys and other things. So standardly, they're at least getting lab draws every 8 weeks. Some kids get them every week, some every 2 weeks, some every 4 weeks, depending on the meds they're on and what their results have shown in the past. But at the minimum, every 8 weeks. And that will continue for literally the rest of their lives while they're on medication. So just even learning how to get through a lab draw is going to be a life skill for them. So a lot of the treatments are pain management and stress reduction. And so a lot of non-pharmacological techniques for this, especially because if, like me, you were diagnosed in infancy or young childhood, you don't want to start on narcotics that young. Your tolerance builds and builds and builds, and you'd be on such a high dose. So, and it's hard to function daily if you're taking narcotics every day. It's not like a short term, like after surgery or cancer treatment for these 2 or 3 years. So we're gonna, really just throw a lot of pain meds at you. So pain management, stress reduction, relaxation techniques are really important that Child Life can help with. Therapy, occupational therapy, and physical therapy. Again, this is mostly outpatient or at school, but that really helps. Splints and orthotics are one of the treatments too. Although splinting is less and less now. There's more research and theories that show it's less helpful and actually sometimes harmful, but you still will see splinting and definitely some like foot orthotics and things like that. So they might come into your clinic if you're covering like an orthotic clinic and have to get the casting and then get it sawed off and go through the whole process of getting like a custom orthotic. And that can be really scary for kids. It's like multiple castings and multiple issues with cast saw. Or if you have younger kids, even though it's not a poke or a shot, they can benefit from Child Life Prep and support for that, just like you could in ortho clinic with getting casts on and off. Again, like I said, both diagnosis itself, the diagnosis process, again, it's not a single test, and the monitoring for meds and the disease includes a lot of labs and blood draws. And the diagnosis process itself and the monitoring includes a lot of radiology procedures, from x-rays to MRIs to bone scans to sometimes some nuke med bone scans. So again, you might be seeing these kids if you're like a interventional radiology or a radiology child life specialist in that department. If you get them, you have time with them, maybe, if you have a handout at your facility that says like Buzzy, Shot Blocker, Elmex cream, comfort holds. These are some simple distraction techniques or distraction techniques by ages or things you can create that you're starting to see now in your coursework. Those are great things. They're in for a nuke med scan and you see them, but you can hand them these pamphlets because you're a great educated child life specialist from Edgewood College, that they're having a lot of injections and infusions and lab draws at home. So even though you're not seeing for a poke, you can hand mom or dad this resource or give them your handout at your hospital for pill swallowing techniques or things like that. And if you don't have that at your hospital already, that's a great thing to develop as like a QI, quality improvement, performance improvement project. I think one of the things you're learning is that as child life specialists, often we only have a short time with patients and we can't address everything face to face. So what a lot of great child life programs do is have these handouts and resources or resources on their website. Like we have a lot of procedure teaching sheets on our child life website at AFCH. And one of your projects is you'll look at some of the preps on some of the websites for, I think that's materials and methods where you're doing the online prep reviews. But, whether it's a physical handout or something on your website, a lot of good child life programs are developing these resources that parents can have access to or get when they're at home and not face-to-face with a child life. And that's one way we can kind of extend our teaching or psychosocial support beyond the time we have face-to-face with patients and families. So joint aspirations is another big one. That's where they don't do this all the time for flares, especially. So flares is a word that people in the rheumatology community and other communities like Crohn's, colitis usually use the term flares. There's some other diseases. That means basically an exacerbation of the disease or a time or a period where it's not controlled really well. In other diseases, maybe it's exacerbation that's used or a different term, but typically in the rheumatology community, it's called a flare up, or we'll say flares, or I was flaring. Sometimes you might overhear me in conversation with Katie or someone saying, "Yeah, I flared last week," or "This weekend was a bad flare. I was in the hospital because I flared." Like, means a bad exacerbation of the disease. So it's all your joints, and they don't usually do this. But sometimes what happens is you have like just your knees are super inflamed. They try different meds or increasing different meds and things, and they can't get it down. And when it's so inflamed, you can't bend it, and that really impedes function. Impedes your range of motion, which impedes function. And so they'll do joint aspirations. And so what that means, or some people say joint taps, is they actually stick a big old needle into the joint capsule, for instance, a knee, but they can do this on hips and elbows. Some people do it on ankles, but knees, hips, and elbows are the big joints that they do this on. And they actually pull out, draw off that synovial fluid, and then they can also just then inject some cortisone, some steroids right into the joint too to help. And so as kids get older, or in community hospitals that don't have sedation clinics, they just do this in the office. Maybe they'll use a little Payne's Freezy spray, maybe nothing, maybe, a little numbing cream. They inject with lidocaine into the joint, then pull that out, and inject with a big old joint needle, which is like, where's my camera? There. It's like this long and really thick on a big old, like, 400cc syringe. It just looks like horrible. And even though they've numbed the skin with the lidocaine, there's still a lot of pressure in the joint. So you might be seeing these kids in sedation clinics at children's hospitals sometimes when it's the younger kids, the toddlers and preschoolers that need this. They'll do some sedation in sedation clinic for this, especially if it's multiple joints. But as kids get older, they're just doing this in the doctor's office, like on the exam table. Growing up, they didn't have these wonderful sedation clinics. So all my joint taps have never been sedated for any of them, even when I was younger. It was a hold her down and get it done when I was really little. I just learned to deal with it as I get older. But that's a big thing. You might see these kids in the hospital for ortho surgeries. Again, that's less and less in childhood because our meds are getting better and better. So now it's getting more and more that the ortho surgeries are happening more in adulthood for these kids. But you'll still see some kids maybe with severe arthritis that are getting not just joint replacements, but there's other things that they can do, other ortho surgeries to help with joint deformity, sometimes fusions or changing around tendons. And I mean, I've had over 37 surgeries. 36 of those have been ortho, and only 4 have been joint replacements. All others have been non-joint replacements. So fusions or pinnings or things like that. You might see them hospitalization for really, really severe flares for surgeries. Sometimes for diagnosis if they're in a really severe flare at the time. But mostly diagnosis is done outpatient now. So they just kind of keep coming back for tests, outpatient tests in clinic. And when I was diagnosed, I was in the hospital for 3 months until I was diagnosed as a infant. But as many diseases, you're learning, kids used to have their tonsils out and be in the hospital for a week, and now it's pretty much an outpatient procedure. They come in and go out. So as we move more and more to outpatient, again, what we're seeing is the kids are still having all the same psychosocial issues and concerns. It's just happening at home, and they don't have the support they could benefit from and that they need. And that's not just from child life, not just from juvenile arthritis, other diseases are like that too. So you can actually get inflammation in your eye. It's called iritis. So kids have to go to the eye doctor a lot. In fact, at diagnosis, you usually go and get a slit lamp test every month. And then if you're not seeing symptoms, like after a year, they might switch you to every other month and then every 3 months. So a lot of eye tests. And some kids, even though it's not invasive, I still have a hard time with things touching my face and coming close to my eye. And then there's certain medications that are treatments for arthritis that after a long time, you can get a buildup of toxicity. So iritis is actually the leading cause of blindness in children that's not congenital. So it's not like they're born with blindness. It's the leading cause of acquired blindness in children. So a lot of kids have to do steroid drops too, which, eye drops in a 3-year-old, even eye drops in a 10-year-old sometimes. Does not go well. And they're doing this, maybe 4 times a day at home. So teaching techniques for comfort positioning again and other procedural support techniques for eye drops. And then dental care. There's a whole host of reasons. You can get inflammation of your gums, just like you get inflammation of other areas. A lot of the meds cause dry mouth. A lot of the jaw deformities cause different issues with the teeth in the mouth too. So kind of historically, kids and adults with JA have really crappy teeth. And dental care can be hard too with the jaw opening. So again, we've learned how much just the average kid likes the dentist, and then if your jaw is already hurting. But know that a lot of them have to go to the dentist more often than just their once-a-year teeth cleaning. And so prognosis, there's no cure, it's chronic, it's lifelong. Kids do not grow out of it. Some kids will go into remission, which means a quiet period of their disease, but it's not that they're cured and it could come back anytime. And there are some people that you'll still hear say, oh, some kids grow out of it, and that's not true. You'll even hear next week in Courtney's lecture that she kind of slipped up and said that, and she doesn't apologize in the lecture, she apologizes later. She meant that some kids go into remission in adolescence, but kids do not grow out of it. That's actually one of my pet peeves. So now let's go into the psychosocial issues and concerns. So for this, I'm going to show you a video, and in the module folder, I'll have the video just itself linked to below these lectures in case that's easier for you or when you're going back to review. So there's an annual nationwide JA conference every year. In 2011, it was in DC. And there's like parent track and kid track and sibling track. And the 16 and 18-year-old kids with arthritis and their siblings, one of their projects for the week was to make a video. They could make it on anything they wanted. So this whole video was from concept to creation to script to production. So part of it was they brought in people to teach them how to do like video stuff, and all that was fun to learn too. But this was all completely done. In fact, the idea for the video didn't have to be something about arthritis. This is what they picked. Was done by the teenagers. So these are 16 to 18-year-olds that are kids that have grown up with juvenile arthritis or that have siblings with juvenile arthritis. So it just kind of gives you an introduction to some of the psychosocial issues and concerns. So I'm going to show you that video.
Of like knuckle pain, knee pain, elbows. It's a disease that older people get, like bone degradation, I think, around the joints.
My grandmother has it, and she can't knit blankets anymore.
Pain in my grandmother.
I think of swollen joints and pain, and
I always associate it with older people.
something that old people get.
It's something related to old people.
I think of my grandma and how she can't move around.
Well, that's all, yeah.
Not
Yeah.
us.
Something that old people get?
Oh, old people. That's the only people that get it, right?
Right.
One minute you're fine, and the next you're in a flare up.
Changing medications makes me feel like a test rat.
Sometimes the side effects are worse than the disease.
When you have JA, it's easy to get angry at yourself.
I feel lonely when I can't join in.
I feel guilty because I can't help my sister in her time of need.
Depression comes and goes with arthritis, and sometimes I feel like I can't talk to anybody.
Sometimes I feel invisible.
And sometimes I feel like I'm 90 years old.
We're all still just kids.
Oh yeah! I just wanna be okay, be okay, be okay. I just wanna be okay today. I just wanna be okay, be okay, be okay. I just wanna
Just because you're arthritis doesn't mean you're alone.
I just wanna feel the day, feel the day, feel the day. I just wanna feel something today. I just wanna feel the day, feel the day, feel the day. I just wanna feel something today. Open me up and
The JA conference is great because you get to meet people just like you.
I'll be your repair, I may be, and give me back my broken heart. I just wanna know today, know today, know today. I just wanna know something.
The JA conference is great because I've learned how to help my sister.
Know today, know today, know today. Know that maybe I will be okay.
We may all be different, and in some cases, a little weird, but we've come together in the spirit of hope, strength, and courage to raise awareness and say it's okay to have arthritis.
Because kids get arthritis too.
Like my sister.
I just
And
wanna
me.
be know that maybe I will be okay. Know that maybe I will be okay.
Of like knuckle pain.
Okay, so hopefully that recorded. Sorry, pop-ups. So, there you go. So, the psychosocial effects and issues for patients of the different disease levels. I'm going to let you guys really figure this out. This is what you'll have to do in your career. You're not going to learn every disease that's out there. We're teaching you some big ones right now, but think about what are the common psychosocial issues and concerns on each developmental level for kids with chronic illness in general, and then think about what you've learned about about what juvenile arthritis is and the treatments and things like that, the characteristics, like we've talked about, fatigue, pain, lots of pokes, having to do pokes at home, eye drops. It's an invisible disease. The diagnosis process is hard. You know, teachers don't believe you. Adults don't believe you all the time. You're different from your kids, different from friends, some of the things you just saw in the video, and really think about what the psychosocial effects and issues are for each age level. So this is one of the I Am the Face of Arthritis. You can tell that's Arthritis Foundation campaign. You saw it in one of the other posters. And this, if you can't read it, this boy is saying, my arthritis won't let me do things other kids can do. I have to get injections every week that really hurt. And he's 11 years old. So that gives you a little clue into some of the psychosocial effects and issues. But I'm going to really let you guys think about that. Effects on families, again, same as the other chronic illnesses, and add in, having to give your kids shots and hold them down at home. The really frustrating process of diagnosis, not even knowing that juvenile arthritis was a thing, that your kid could get it. So think about primary caregivers and parents, siblings. And again, I know we always sometimes focus on siblings, the jealousy and the time lost with parents and things like that. But really think about that video where a lot of the kids said they felt guilty because they didn't know how to help their brother or sister with arthritis, or they felt sad when they saw them in pain or worried about them. Siblings do have, jealousy and frustration with their siblings with chronic illness, but I think sometimes we overlook the fact that siblings also worry about their brother or sister with chronic illness and feel guilty that they can't help them and feel frustrated and are concerned for their future and have all the same concerns and worries as their parents and other people that love them. And often, they have those emotions all wrapped up at the same time. Maybe they're really frustrated and angry because their brother or sister is flaring and mom and dad have to take them into clinic or they have to stay home. So, there's only one car and one person to drive. And so the wild brother or sister is missing an event at school or something like that. And then they also feel all at the same time really bad for their brother or sister with arthritis that's in pain and feel guilty that they can't do more to help them. And they feel bad that, they can run around outside and play that day and their brother and sister can't or whatever. And they often have those emotions at the same time. So think about how it affects the whole family. Really reference and think about the family systems theory and the ecological theory. You know how I all love Bronfenbrenner, especially when it comes to chronic illness. So who's ever doing the effects on family, and when you're thinking about this, really look back at those theories and try to tie in the concepts of those theories to what you've learned about with their juvenile arthritis. And then again, with Bronfenbrenner's theory, school, it's not just the family that is affected by the arthritis and affects the child with arthritis, but really school, community, and national laws. Brown versus Board of Education, Section 504 of the Rehab Act, Public Law 94-142, the ADA Act, the HIPAA Act, and the latest healthcare reform on patient privacy and affordability. Patient Portability and Accessible Care Act in 2010. That's the Obamacare Act, but a lot more things went into that affect kids with chronic illness and pre-existing conditions and access to insurance and ADA access to employment. 94-142 was just access to health care. So, before Public Law 94-142, which is now the IDEA law, Individuals Disabilities Education Act, schools didn't have to accommodate kids with disabilities. Kids with disabilities often didn't get public education. They were at home. Those included back then kids with arthritis in the wheelchair. So those are big things that have affected. And now with 2010, with, people think of Obamacare of just the insurance, but a lot of the laws were surrounding the portability part of it, of not being able to be covered even if you have a pre-existing condition, and some of the other laws that have really helped kids with chronic illness. So again, some of the child life interventions are preparation and support for all the pokes and procedures that we talked about in the medical information. So remember the list. This is a hint for quiz and exam. Remember the list of all the procedures we discussed as part of the treatment options, and think about what you would do for preparation and support for your child life interventions, for a lab draw or a joint aspiration or an eye exam or eye drops or whatever. Surgery prep and support if they need surgery, hospitalization, inpatient support and services, including like pre-admission tours if it's scheduled, teaching pill swallowing and even just med taking compliance, therapy, home, like their OT-PT and home exercise routine compliance, like helping parents learn in positive incentives or behavioral charts, teaching pain management, relaxation, stress management, coping skills, sibling issues and support, parent support, school issues. School visits are a big one with this, school reentry, or getting them hooked up if you have a social worker or nurse practitioner that does a lot of the school issues. A lot of times there's letters for modified FIED, teachers not believing kids when they're in pain and need to go to the nurse's office, educating nurses about it, needing extra passing time, needing a locker on every floor, an extra set of textbooks at home, especially in the high school, and the textbook gets like this. So oftentimes, most of the time, kids with JA have either a 504 plan at school or an IEP plan at school, an individualized education plan. Transition to adult care. We've talked about this with sickle cell. Again, this is a lifelong disease. So that prep support resources, all that you learned about in the transition module is really important with juvenile arthritis too. Connecting to community resources. So again, what we've talked about with other chronic diseases, one of the best things we can do is connect them with that nonprofit that has community resources in their area, whether that's, the Cystic Fibrosis Foundation, the JDRF for diabetes, Crohn's and Colitis Foundation, that they can help provide a lot of family support and psychosocial support. So specifically, Arthritis Foundation has camps, Camp Ashland, Wisconsin. We have these power packs, which are a backpack that we send to families who are new diagnosed if they reach out to their arthritis, and it's got a book for parents on raising children with juvenile arthritis. That's a great book. And then it has like a hot pack. So for the younger kids, it's a teddy bear. For the older teenagers, it's just a hot cold pack that they can use. It has a shop locker. It has a binder for parents to keep track of medical information and meds, a lot of different resources. There's a national conference. In Wisconsin, we have National JA Family Day, which I help plan, which is a lot of educational speakers for the parents, therapeutic activities for the kids and siblings, and then networking time. There's JFAN, it's Juvenile Arthritis Family Network. They're not calling them mini JA days, that are monthly networking meetings that run throughout the year except the 3 summer months. So it's once a month. We have Madison, Milwaukee, and Green Bay in Wisconsin right now. And some of the students have helped with those. So it's once a month, usually on a Saturday, like 10 o'clock to 1 o'clock or something like that. There's some sort of speaker educational component for parents. And then we have some sort of education or therapeutic activity for the kids and siblings, or something. Sometimes it's all together as a family, like going to a cooking class or something like that to learn. So a lot of times the child life students help me do the kid part of that. We have peer mentoring, especially for new diagnosis, arthritis, introspective, and young adult kind of networking education. We don't really call it groups. We don't really call them support groups anymore, because it's not just like people think of support groups and they think just sitting around in a circle and kind of complaining about life and your disease. And what we really try to focus on is some sort of educational piece each time we meet, a different educational piece. And then obviously there's the networking and support. That's important. Nationwide, we do Jingle Bell Run and May Arthritis Walk, and these are in cities all across the country. In Wisconsin, it's everywhere from Sheboygan to Wausau to La Crosse, Madison, Milwaukee. And even though it's a fundraising event, it's also a networking event. We always have like educational tables and resources set up. And then in Madison, I always run a kids zone table at all of them, so the kids and siblings and even, cousins and friends and who's ever on the walk team for the parents can come over and do a therapeutic activity. And often the child life students help with that. So like last year, it was right at Viola Sioux, so it wasn't far for the Edgewood people. And we made stress balls, and I did some mandala coloring and things like that. And then other events. So, and then it's important to remember, we've talked about with other chronic illnesses, especially when you're doing education about the disease or teaching coping skills, to remember to adapt and re-educate and re-teach and support all these interventions to each of the developmental level, from infancy through adolescence and young adulthood. But that transition we see in a lot of chronic illnesses is often the child's understanding of their disease is to the whatever the cognitive developmental level was when they got diagnosed. So if they got diagnosed at 16, they may have a more sophisticated understanding of their disease. But what we often see is like kids who get diagnosed at 3 or 4 when they're 16 still understand their disease as like a 3 or 4-year-old, not because they're developmentally delayed, but because we taught them at 3 or 4 about their disease and never retaught them as their cognitive development advanced. And so, as I've talked about with and that's not just teaching about the disease, but teaching about the medications and why it's important and how their meds work and coping skills and pain management techniques. We need to do that at every developmental level, as I've talked about with other chronic illnesses. So as you're learning, as we're getting towards the end of the semester in this class, there's a lot of common themes with pediatric chronic illnesses, right? Especially from the psychosocial world, that the diseases may be different, but a lot of the psychosocial issues and concerns and effects on family and parents and siblings are really similar across the chronic illnesses. Hopefully that's kind of like getting hammered into your brain right now. So some of the unique things about juvenile arthritis or the world of pediatric rheumatology, whether it's lupus or dermatomyositis or ankylosing spondylitis, is that we say KGAT, kids get arthritis too. There's a big lack of public awareness and even lack of knowledge in the medical community among providers that don't realize that kids get arthritis and this is an old people's disease. So you can imagine like a 10-year-old coming to school and saying, I have arthritis now and, you know, my knees hurt and I can't go to Phi Ed, and they look perfectly fine. And the teacher is like, only, you know, elderly get arthritis. This kid is like, you know, they don't believe them. Or having a handicap sticker when you're a younger kid and you look like, or even my age with a handicap sticker, I get a lot of flack from people all the time. So a lot of different issues. So there's a lack of pediatric rheumatologists in the U.S. and around the world. A huge issue with the shortage of pediatric rheumatologists in the country. So the travel time and the cost, the time away from family, friends, school for the patient, for the parents, the time away from work to see the peds rheumatologist. And a lot because the peds rheumatologists are so overloaded, they don't get to see their patients as often if they would like, and so it's harder to get the disease under control because maybe normally where they'd want to see them like every 3 months, they're only able to see them once a year because of the travel and the distance, or the rheumatologist is just so overloaded with patients. So we're kind of lucky in Wisconsin. We have pediatric rheumatologists in Madison and Milwaukee, and we used to have one that worked part-time in Green Bay, and then we lost them, and now we've got one part-time and a new one full-time starting. So we're pretty lucky, but the people in the UP are up in like Marshall or Wausau or way up north in, you know, Ashland. They still have to travel to either Green Bay or the Twin Cities, and there's a lot of states that have none. So because of this, like we talked about, the length of time between schedule and appointment and visits for controlling the disease, but also because of this, peds patients often are treated in adult clinics by adult doctors. That was me all growing up. I didn't have a pediatric rheumatologist until 8th grade, I think. So imagine the stigma of sitting in a waiting room full of like, you know, you're 10 and everybody else is 70 and 80 and 90. And also we've talked about, especially in the transitioning, the difference between an adult-focused staff and adult environment where you don't have child life and social work and maybe nurse practitioners and case management. It's not a multidisciplinary approach with OT and PT. And, you know, when you go to a peds provider and they come in, they ask parents, you know, how are you coping? How you doing? How's school? How's the OT PT at home? Or going to adult provider, it just comes in and they're like, how's your disease? How's your joints? This is the med, switching the meds. And they don't even get into, you know, how are you coping? How's your mental health? So that's an issue too. Again, the lack of knowledge in the general medical community that don't realize that kids can get arthritis too, or even infants and toddlers. And we've talked about the process of the diagnosis, the length, the unknown, the frustration. It's a hidden disease, like we've talked about, one of those indivisible diseases, and it's really erratic and unpredictable. Like I've said, and you heard one of the kids on the video say, the teen video, that like one day I'm fine and the next day I'm flaring and I can't move. And that makes it really hard to plan. That's one of the frustrating things with arthritis, besides the fatigue. That's really hard to, even when you've lived with it 37 years and you're a child life specialist that has great coping skills, the fatigue and the difficulty in planning and having to cancel things at the last minute is really, really frustrating and hard to cope with. It's hard to be believed as adults because maybe the kid one day they're fine and they're running around, and then the next day, you know, they say they can't do anything at school or they can't move, or the kid was fine on Sunday and now going to school on Monday, they say they're in pain and flaring. Like, how do parents believe them, or what do they believe? Or even, maybe in the morning they're not feeling good and they're late to school, but then and morning stiffness is mornings tend to be high, much more difficult for kids and adults with arthritis. So classically, and historically, hence you'll never see me teach a class before noon. Unless I'm covering for Katie. Katie's classes will be at 8:30 a.m., but mine will never start before noon. And that's one of the reasons mornings are really, really challenging and really hard to get kind of the joints moving, because you've been sedentary and the joints have really gotten stiff all night. So you might be, kid may be late to school in the morning, and then by after school, they're ready to go to their club or their activity, or they're running around at recess. Again, we've talked about the issues of it being very outpatient focused, like a lot of other chronic diseases, but that's harder because kids and families don't get not just child life support, but social work, nurse practitioner, all the chaplain, all the services that we have. And a lot of parents are having to deal with all these things at home on their own. And then biologics is this new class of medication that I was in the FDA phase 3 trial in 1999 for the first biologic that came out called Enbrel, and now there's many more. But it is outrageously expensive, even with insurance. So I've had good insurance because I've worked at hospitals. Now I work at Edgewood, which has, GHC, good insurance. So I've been blessed with very good insurance my whole life as an adult. And my cheapest biologic, my copay is $8,000 a month. Get the infusion every 4 weeks. The $8,000. That's my copay. The drug itself is exponential cost, and that's the cheapest one I've been on. So that's out of pocket. This is one of the reasons I work so many jobs, is so much of my income goes to not only that, but splints and orthotics and the wheelchair, and those things aren't covered 100% by insurance. Sometimes they're not covered at all. Sometimes they're in that durable medical equipment category where they're covered 80-20 or 60-40. You'll learn more about that as you get on your own insurance, but it's a huge burden on families, the cost. And again, the travel, if you're in North Dakota and the nearest rheumatologist for a while was in Twin Cities, we lost one of our Madison rheumatologists because he actually went to South Dakota, and now he's the only rheumatologist in South and North Dakota. So if you're way up in the upper, northwest corner of North Dakota and you're traveling all the way to South Dakota, that travel time, those flights or that driving, the hotel, the food, none of that's covered by insurance. And that's not like a simple gas card home in Madison that a hospital can hand to you. So all that stuff really adds up that people, I think, we don't always think about in the medical community. That's really a burden on families. And kids feel it too, especially as they get older and start to realize the school age and teenagers, I can't even tell you how many times I've had kids tell me they feel so guilty because, sorry, I'm really sniffly. They know that, family isn't going on vacation, or their brother and sister can't have ballet lessons or go to this basketball camp or whatever, because they know the family is having a budget because of their medical costs. Like, kids are not immune to that guilt. So again, national shortage of pediatric rheumatologists. There's 8 states that do not have a single board certified and practicing pediatric rheumatologist, and 5 states that only have one. Let's see if it'll go to the map. I don't know. Hopefully the map will come up. It's trying. It's thinking about it. All right. Oh, there it is. So the purple don't have any pediatric rheumatologists. So if you live in Alaska, you got to fly to the mainland to see a pediatric rheumatologist, or you're just seeing adult providers. And again, it's a completely different disease besides the developmental and psychosocial of having an adult provider. And again, we now have one in South Dakota, Grant Severson, who used to be one of ours in Madison, but still all this area is either having to go to Washington or Oregon or come here. And then these green states only have 1. Orange states only have 2. Yellow only have 3. and the white states have 4 or more. But still, even like Wisconsin, where we have Green Bay, we have several in Milwaukee and several here in Madison. If you live like way up here or way up in the UP, you know, and you're having to travel, and this is Michigan has 4 or more, but it's not like CS Mott's that has it. So if you're in the UP, you're traveling way down and over. Still a lot of travel costs. So there's fewer than 350 pediatric rheumatologists in the country that to serve 300,000 children with JA. Thus, only 25% of children with JA are getting appropriate care and treatment. 75% are not. So that's a big issue. This is my disclaimer. I do work and volunteer for the Arthritis Foundation. Part of my work is volunteer, and part of my work I get a stipend. So here's my little disclaimer, and I am the medical psychosocial director of Camp MASH. But Camp MASH and our JA camps around the country are great to provide psychosocial support for kids, and they're life-changing. And if you want to be a counselor or other volunteer, so the practicum thing is done and set for this year. We already have a practicum students, but we are we're kind of in the last days if you want to interview to be just a regular volunteer, which is much easier. So you have to be able to commit to August 4th through the 10th. You could do a counselor for a cabin or just a regular volunteer too, depending on what we need. Like last year, one of the Child Life students came and helped with the art program for the week. So you don't have to do any planning or any work in the summer. You just come up and show up for that week, and we orient you and give you all the tools that you need, unlike the practicum, which is kind of a whole summer thing with multiple modules. So if you're interested, email me ASAP. But this is to kind of show you some of the psychosocial issues and concerns and what we can do as child life specialists in the medical community to help support them. So I'm actually going to do this because I have it pulled up already.
Kind of took us by surprise and didn't really know anything was wrong until she bumped her knee one day, but she didn't really bump it that hard, and it was swollen like she had an accident with it. And that's what the first sign that we had, that there was something wrong.
Sometimes they just think it's normal, but to other kids, they don't have that pain.
To have arthritis as a child, it tends to be pretty isolating.
I've been getting infusions since I was 4 years old, so that's 14 years now.
I really like sports, so having to be limited on those kinds of things was not fun.
It can affect your joints as well as your organs. So, like when I was 8 years old, it affected my heart and my lungs, and I was hospitalized for 4 days.
It's really difficult, especially because a lot of people don't know what it is, don't know kids can get it, and on the outside we look like normal teenagers, but on the inside it hurts.
There's actually 300,000 kids in the country with arthritis, and this camp for these kids is literally heaven on earth.
MASH stands for Make Arthritis Stop Hurting. So Camp MASH is a camp for kids ages 8 to 17 to come and hang out with other kids who are just like them.
I had sat in waiting rooms my whole life with people that were my grandparents' ages. And so Camp MASH is the place where I first met another kid that had juvenile arthritis.
It's incredible to have all the kids and the counselors and the other adults, that they all understand what you're going through.
You can just be yourself, and you don't have to worry about anybody judging you about if you're tired or what medications you're taking. Everybody understands what you're talking about.
They're not Madison with arthritis. They're not Abby with arthritis. They're just normal kids here.
It's amazing to watch these kids grow and change and develop and actually get in the pool and try new and different things that they might not normally get outside of the Camp MASH experience.
You're able to learn about things with arthritis. You're able to spend time with people who have arthritis. It's really fun.
They have rotations of arts and crafts and games, and they always have a rotation of life skills. We do a lot of transition teaching with the teenagers of how to transition to adult care themselves.
Some kids come in here not knowing how to do certain things to help their illness. Like some kids don't know how to take pills, how to give themselves shots. And at the end of the week, like the amazing nurse staff can teach them that, and it benefits them in the long run.
It's more than just any other camp out there because you have this component where there's a really deep reason why we're here. It's almost like coming back home for these campers.
I don't know what I would do without Camp MASH. I love Camp MASH so much.
There's some.
Okay, I apologize. My computer died in the middle of that, so hopefully this recording still works. I'm going to show you the Camp MASH video again. I don't know how much recorded or not. The disclaimer I'm supposed to say whenever I show this video is that Maddie says I'm always supposed to say that her reason her hair doesn't look beautiful, here she is that she just came out of swimming in the pool. And then our two teenagers that got interviewed, Bailey and Callie, wanted me to say that when they said nurse staff, they teaching them about shots and all that, they meant nurse and child life staff. It's just we're all kind of the medical team together at camp, and we're housed in the nurses station. So those were the two disclaimers that I'm supposed to say per the kids anytime I show the video. All right, so let's try this one more time. I apologize for the technical difficulties. We are having a day here.
Kind of took us by surprise and didn't really know anything was wrong until she bumped her knee one day, but she didn't really bump it that hard, and it was swollen like she had an accident with it. And that's what the first sign that we had, that there was something wrong.
Sometimes they just think it's normal, but to other kids, they don't have that pain.
To have arthritis as a child, it tends to be pretty isolating. I've been getting infusions since I was 4 years old, so that's 14 years now.
I really like sports, so having to be limited on those kinds of things was not fun.
It can affect your joints as well as your organs. So, like when I was 8 years old, it affected my heart and my lungs, and I was hospitalized for 4 days.
It's really difficult, especially because a lot of people don't know what it is, don't know kids can get it. And on the outside, we look like normal teenagers, but on the inside, it hurts.
There's actually 300,000 kids in the country with arthritis, and this camp for these kids is literally heaven on earth.
MASH stands for Make Arthritis Stop Hurting. So Camp MASH is a camp for kids ages 8 to 17 to come and hang out with other kids who are just like them.
I had sat in waiting rooms my whole life with people that were my grandparents' ages. And so Camp MASH is the place where I first met another kid that had juvenile arthritis.
It's incredible to have all the kids and the counselors and the other adults, that they all understand what you're going through.
You can just be yourself, and you don't have to worry about anybody judging you about if you're tired or what medications you're taking. Everybody understands what you're talking about.
They're not Madison with arthritis. They're not Abby with arthritis. They're just normal kids here.
It's amazing to watch these kids grow and change and develop and actually get in the pool and try new and different things that they might not normally get outside of the Camp MASH experience.
You're able to learn about things with arthritis. You're able to spend time with people who have arthritis. It's really fun.
They have rotations of arts and crafts and games, and they always have a rotation of life skills. We do a lot of transition teaching with the teenagers of how to transition to adult care themselves.
Some kids come in here not knowing how to do certain things to help their illness. Like some kids don't know how to take pills, how to give themselves shots. And at the end of the week, like the amazing nurse staff can teach them that, and it benefits them in the long run.
It's more than just any other camp out there because you have this component where there's a really deep reason why we're here. It's almost like coming back home for these campers.
I don't know what I would do without Camp MASH. I love Camp MASH so much.
There's something so beautiful and so magical about being here and how much everyone clicks over one thing and how it can be that simple.
I like to say that dreams can come true here. It's so unique and so diverse and so welcoming and loving. It's the best place on earth.
Hi, we're the Downies. This is Susan's house. The reason...
Okay. So, you may or may not have noticed that a lot of those activities were child life interventions. There were kids working on their canvas before they splatter painted and working on gloves, stress balls, and learning other life skills. And there were a lot of child life students in those shots, especially when the kids were coming up to the nurses to take their meds. That was a child life student by standing by each nurse to help with pill swallowing and compliance and all that. So a lot of child life involvement. So thank you for listening and learning about juvenile arthritis. If you have any questions, even later after this course, or want more information on a specific topic about pediatric rheumatology, please email or talk to me.